Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Clinical Pathologic Significance of Mismatch Repair Defects in Endometrial Cancer, an NRG Oncology Gynecologic Oncology Group study of 1,024 endometrioid carcinomas by McMeekin et al. My name is Matt Yergelin, and I'm an instructor of medicine at the Dana-Farber Cancer Institute and Harvard Medical School, both in Boston, Massachusetts, USA. My oncologic specialty is hereditary cancer syndromes and gastrointestinal medical oncology. Mismatch repair deficiency represents a distinct neoplastic pathway in which replicating DNA is particularly prone to small insertion or deletion events at mono, di, tri, and tetranucleotide repeat sequences throughout the entire genome, a phenomenon known as microsatellite instability. Both inherited and sporadic forms of mismatch repair deficiency underlie a significant fraction of both colorectal and endometrial adenocarcinomas. Germline mutations in the DNA mismatch repair genes cause Lynch syndrome, a relatively common inherited syndrome that portends markedly increased lifetime risks of a variety of cancers and is thought to underlie roughly 3% of colorectal cancers and 2% of endometrial cancers. Sporadic mismatch repair deficiency, on the other hand, is typically induced by epigenetic silencing of the MLH1 gene caused by hypermethylation of the gene's promoter region. The clinical pathologic considerations of both inherited and sporadic mismatch repair deficiency are reasonably well understood in colorectal cancer, where Lynch-associated colorectal cancers are typically young onset, have particularly favorable prognoses, and fail to benefit from adjuvant fluoropyrimidine monotherapy, even though they often display poorly differentiated signet ring cell and or medullary histologic patterns, factors that are otherwise associated with poor prognoses. Colorectal cancers with sporadic mismatch repair deficiency likewise fail to benefit from adjuvant fluoropyrimidine monotherapy and tend to have more favorable outcomes than mismatch repair proficient cancers, in spite of their propensity to have poorly differentiated signet ring cell or medullary histologies. Unlike Lynch-associated colorectal cancers, however, sporadic mismatch repair deficient colorectal cancers usually arise in older patients and often harbor somatic mutations in the BRAF oncogene, which are associated with particularly poor outcomes and thus likely attenuate the otherwise favorable prognosis from mismatch repair deficiency. Thus, in colorectal cancer, mismatch repair deficiency status is felt to be both a favorable prognostic biomarker and also a predictive biomarker in that it indicates lack of benefit from adjuvant fluoropyrimidine monotherapy, at least in stage 2 disease. In contrast, such predictive and prognostic implications are not well understood in mismatch repair deficient endometrial cancers, which disproportionately demonstrate endometrioid-type histology. In the study that accompanies this podcast, McMeekin and colleagues address this gap in knowledge with their analysis of 1,024 endometrioid-type endometrial adenocarcinomas from women recruited to GOG 0210. The investigators performed microsatellite instability analysis, mismatch repair protein immunohistochemistry, and MLH1 promoter methylation analysis in order to classify each cancer into one of 4 mismatch repair status categories. 1, mismatch repair proficient, 2, MSI low, 3, probable Lynch syndrome, or 4, quote, epigenetic defect, indicating a mismatch repair deficient tumor with MLH1 promoter hypermethylation. The investigators then explored for associations between the mismatch repair status categories and various clinical and pathologic factors. Within this cohort, the authors found that women with mismatch repair deficient tumors, both those with probable Lynch syndrome and those whose tumors had epigenetic defects, were more likely than the other categories to have tumors with higher histologic grade and lymphovascular invasion, both features typically associated with poor prognoses. Women whose mismatch repair deficient tumors had epigenetic defects were significantly older and had significantly higher stage than other categories. In spite of these features typically indicative of worse outcomes, multivariable analysis revealed no significant difference in either progression-free survival or endometrial cancer-specific survival in women with probable Lynch syndrome or epigenetic defect tumors compared to other groups. To examine the question of whether mismatch repair status is a predictive biomarker in endometrioid-endometrial adenocarcinomas, the investigators examined for interaction between mismatch repair deficiency status and outcomes from adjuvant therapy. Both women with probable Lynch syndrome and those with mismatch repair deficient tumors with epigenetic defects were more likely to have received some sort of adjuvant therapy compared to women with mismatch repair proficient tumors. However, no statistically significant interaction was ultimately found between mismatch repair deficiency status and outcomes from adjuvant therapy. This large cohort provides important insights into the prognostic and predictive significance of mismatch repair deficiency in women with endometrioid-type endometrial adenocarcinomas. As has consistently been seen in mismatch repair deficient colorectal cancers, mismatch repair deficient endometrial cancers arising through both sporadic and suspected germline mechanisms were significantly more likely than their mismatch repair proficient counterparts to demonstrate histologic features that typically indicate poor prognosis, including high-grade histology and lymphovascular invasion. In spite of this association with such high-risk features, however, mismatch repair deficiency status was not significantly associated with outcomes. On the other hand, increased age, higher stage, and poor histologic grade all maintained their status as independent prognostic factors with inferior progression-free survival and endometrial cancer-specific survival on multivariable analysis. The authors interpret these findings to indicate that mismatch repair deficiency essentially counteracts the poor prognostic impact of lymphovascular invasion and high-grade histology, theorizing that perhaps increased infiltration by cytotoxic CD8-positive T cells, known to be a feature of mismatch repair deficient tumors, led to improved control of these cancers with otherwise high-risk features through immune-based mechanisms. Such theories are intriguing, but ultimately speculative and in need of further investigation. In spite of the volume of data from this large study, the issue of mismatch repair deficiency as a predictive biomarker in endometrioid-type endometrial adenocarcinoma remains unsettled. On univariate analysis, the authors did find inferior progression-free survival for women whose cancers had mismatch repair deficiency with an epigenetic defect, but this association lost statistical significance in multivariable analysis, essentially confirming that this inferior outcome was driven by other high-risk features such as increased stage and older age rather than mismatch repair deficiency status. The authors performed numerous analyses to investigate for an association between mismatch repair deficiency status and response to adjuvant therapy, and they ultimately concluded that their data suggest that mismatch repair deficient tumors may have improved outcomes with adjuvant therapy. Such conclusions should be interpreted with caution, however, since the associations measured in this study were not statistically significant, nor were any details provided regarding the specifics of adjuvant therapy used by women in this study. Details such as the specific chemotherapeutic drugs used, the use or lack thereof of radiotherapy, and the doses and duration of both chemotherapy and radiotherapy will be needed to explore such interactions more precisely. Several prior in vitro studies have suggested that mismatch repair deficient tumors may be resistant to chemotherapy with cisplatin and carboplatin, likely two of the most common agents used in the adjuvant treatment of endometrial carcinomas. Understanding whether mismatch repair deficiency is a predictive biomarker in endometrioid-endometrial adenocarcinoma in vivo, however, will ultimately require analysis of patients on whom detailed treatment information is available, ideally in the setting of a randomized prospective clinical trial with standardized treatment protocols. In sum, this large, thorough study by McMeekin and colleagues provides important insights into the role of mismatch repair deficiency in the prognostic stratification of endometrioid-endometrial adenocarcinomas. Here, mismatch repair deficiency itself was not a prognostic biomarker, even though it was significantly associated with other histopathologic factors typically thought to confer poor prognoses, such as tumor grade and lymphovascular invasion. Whether or not mismatch repair deficiency is predictive of differential responses to treatment in endometrioid-endometrial adenocarcinomas, on the other hand, remains an open question that will require further study. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.